Hi, this is Dr. Perry Carpenter. I'd like to thank you for taking the time to join me on this week's video. In this week's video, we're in session 4 of our new series entitled Orthopedic Essentials for the Qualified Medical Evaluator. And in this series, we're taking a look at the true positive objective findings for injuries sustained to the spine out of Chapter 15 of the AMA Guides, to the upper extremity, which is Chapter 16, and then also the lower extremity, which is Chapter 17. And the AMA Guides encourage us to focus on positive objective findings in arriving at our determinations either for or against permanent impairments for injuries to the spine, the upper extremity, and the lower extremity. And it seems that many doctors are confused as to what constitutes a true positive objective findings. And many evaluators get confused and sidetracked by examinee subjectivity, and they lose sight of what constitutes a true positive objective finding. So I have a fascinating discussion for you today, and we're going to begin the actual physical examination, beginning with our observation of the examinee. But before we get into the topic of today's discussion, let's just take a couple minutes to review where we've come from so far in this series. In video number 1 of this series, we defined pain and we talked about some pain concepts that you can expect to be confronted with in the face-to-face evaluation with your examinee. And the key concept from that discussion was that pain has a couple of key characteristics. Number 1, pain is defined as an unpleasant sensory and emotional experience. So let's just talk about this for a moment. Don't be surprised when your examinees load their descriptions of pain with emotional descriptors. Examinees are well known and are famous for emotionally laden descriptors when they discuss their painful condition with you. Because pain is not only a sensory experience, it's also an emotional experience. And your job as the qualified medical evaluator is to sift through the examinee's emotional descriptors to arrive at your own description of the examinee's true condition. And this is not always easy to do, because it's easy to become enmeshed and wrapped up in the examinee's emotional descriptors. So you want to pay particular attention to the examinee's emotional descriptors. Number 2, pain by definition is often characterized by what Merriam-Webster Dictionary refers to as evasive action. And it's this evasive action that's going to form the basis of the true positive objective physical examination findings that we're going to seek in our physical examination of the examinee. Now, evasive action is simply a manifestation of the flexor withdrawal response as the examinee attempts to evade or move away from a painful stimulus. So true positive objective findings in the physical examination are characterized by some movement away, some flexion withdrawal response, some reflexive evasive action away from the painful stimulus. In the absence of an evasive action from the painful stimulus, we're simply dealing with an examinee's subjective response to pain. So we're going to focus throughout the remainder of this program on true objective physical examination findings, which are often characterized by some form of an evasive action. Then in session number 2, we talked about different neuromusculoskeletal injuries in chapters 15, 16, and 17 of the AMA Guides. And we said that different tissues in the body, when they're injured, whether we're talking about muscle tissue, neurologic tissue, vascular tissue, connective tissue, ligamentous tissue, tendinous tissue, etc. These various tissues have very characteristic pain patterns and pain responses. Also, systemic and musculoskeletal pain syndromes, which are different pain syndromes, have their own unique descriptors, and examinees will use different descriptors in describing injuries to the musculoskeletal system compared to the descriptors that they use to describe their symptoms in the cases of systemic pain syndromes. So an examinee's report of symptoms should be consistent with the type of tissue and the neuromusculoskeletal structure injured. And many times examinees will use pain descriptors inconsistent with the type of tissue that has been injured. We also talked about the 7 types of repetitive stress pain. This is an important concept to understand in the case of cumulative trauma injuries, which we're all facing with increasing frequency nowadays. And then we also talked about the words of art from the 1997 Permanent Disability Rating Schedule, which still has value today in discovering how bad or how severe or how impactful an examinee's pain actually is on their ability to function in work and daily living activities. So we talked about minimal pain. We talked about slight pain. We talked about moderate pain, and we talked about severe pain. And even though most examinees will describe their pain as moderate to severe, in other words, they'll use numbers like 8, 9, 10, and even 11 on a 10-point pain scale, most examinees' pain can be best characterized as minimal pain. Minimal pain, meaning that they have pain that's there. The pain is a nuisance. The pain is bona fide. But the pain does not actually interfere with the performance of the activity that causes pain. And we use this discussion to jump immediately into our next discussion regarding pain and activities of daily living. With regards to pain and activities of daily living, most examinees, you'll find, if you take the time to do a careful activities of daily living assessment with them, interactively in the face-to-face evaluation with examinees, you'll find that most examinees do not have true limitations with activities of daily living. In other words, most examinees are perfectly able to do all their daily living activities, even though they may have actual and bona fide pain in the course of performing those activities of daily living. In other words, the pain that they have does not rise to the level that it actually interferes with the activities of daily living. So each of the limitations to activities of daily living that your examinee describes is caused by a finite range of conditions and or injuries. In other words, very specific injuries cause very specific limitations in activities of daily living. In other words, to clarify and to illustrate this principle, we would not expect an examinee to have limitations in the activities of daily living involving communication, such as writing, typing, speaking, etc., the communication activities. We would not expect an examinee to have limitations with communication activities in the case of a lumbar spine injury. In other words, the limitations to activities of daily living that the examinee describes should be consistent with their known injury. And further, each of the limitations to activities of daily living in the case of bona fide and actual limitations to activities of daily living, each of these should be accompanied by positive objective physical examination findings that would tend to support the examinee's description of a limitation to that particular activity of daily living. Okay, so that brings us to today's discussion. And in today's discussion, I want to talk to you about the beginning phases of your face-to-face physical examination with the examinee. Okay, so over the course of our next 2 sessions, I want to talk to you about the nature of true objective physical examination findings in the physical examination of your examinee. Now, of course, a discussion of the physical examination of the spine, the upper extremities, and the lower extremities would take hours and hours and hours and is way beyond the scope of this continuing education program. So I want to highlight just a few key points wherein I find there is great misunderstanding among qualified medical evaluators. So in today's session, I want to talk to you about true positive objective physical examination findings that you can determine in your first 10 seconds of observation of your examinee. And then in our next session, I want to talk to you about true positive physical examination findings in the neurologic examination of your examinee, where I find doctors have a great many misunderstanding about what constitutes a true positive finding for neurologic dysfunction. And I want to focus specifically on the sensory examination when we get to a discussion of the neurologic exam. So in today's session, we're going to talk about pain behaviors and what information we can glean about the examinee by observation of the presence or the absence of pain behaviors in the examinee. And then I just want to talk to you about a few general observations that signal positive objective findings in the observation of your examinee. And this will lead directly into our next discussion regarding the neurologic exam. And recall that when we're dealing with the neurologic exam related to the spine, we're dealing with physical examination procedures of spinal nerve roots, whereas when we're dealing with the upper and lower extremities, by the time the nerve roots get into the upper and lower extremities, they've coalesced and conjoined into named peripheral nerves. And I find many doctors are not quite clear on the distinction between the distribution of spinal nerve roots and the distributions of named peripheral nerves in the upper and lower extremities. So we're going to talk a little bit about the anatomy of the important neurologic structures related to the spine, upper and lower extremities. We're going to talk about typical physical examination findings in the presence of an injury to either spinal nerve roots and or peripheral nerves. And then we're going to talk about the physical examination procedures that can uncover true positive objective findings in the neurologic examination. So let's begin today with a discussion of the pain behaviors, and let's see what the AMA guides have to tell us about the types of information that we can glean through observation of bona fide pain behaviors in our examinee. Okay, so the pain behaviors are described on page 579 of the AMA guides. And the AMA guides tell us that pain behaviors are ways that individuals communicate about their pain. Now, as you know, in every communicated message between persons, each message contains both a verbal and a nonverbal component. Well, according to the AMA guides, the pain behaviors may be either verbal and or nonverbal. Now, in my experience, the pain behaviors are most generally non-verbally communicated messages. There are a few pain behaviors such as moaning, groaning, complaining that are verbally communicated messages, but in general, the pain behaviors are non-verbal behaviors that the examinee will assume that gives us great information, again, non-verbally, about their condition. Now, as the examiner, we have a twofold task. Number one, when we see a pain behavior, it becomes important to be able to identify and characterize specifically what is the exact nature of the pain behavior that we're observing. And then once we have the pain behavior characterized, it's necessary to then to make a decision within your own mind as to whether or not that observed pain behavior tends to authenticate the validity of the individual suffering. In other words, whether or not you find that pain behavior to be consistent with the examinee's known injury and the examinee's known condition, or on the other hand, whether or not the observation of the examinee's pain behavior tends to raise questions or concerns about the examinee's sincerity and or their communication style. So as you observe your examinee, both in the waiting room and in the interview and in the physical examination, you're going to be paying particular attention to the nonverbal aspect of their communication, and you're going to be making an assessment as to whether or not the pain behaviors are consistent with the known condition and the known injury, or whether the pain behaviors are inconsistent with the known injury and the examinee's known condition. Now, in making this distinction between consistency and inconsistency of the examinee's pain behaviors with their known injury and their known condition, the AMA guides on the very next page, on page 580, give us a great clue that assists in making this critical decision. The AMA guides tell us that pain behaviors, in other words, the pain behaviors, those particular behaviors that tend to validate an individual's pain, are generally specific to that person's medical condition, whereas exaggerated pain behaviors that tend to discredit the examinee's suffering and tend to discredit the examinee's display of pain, such as emotional displays, such as pain-limited weakness, these tend to occur in conjunction with a wide variety and across many different types of medical conditions. And I remember the very first time I myself observed a pain behavior. I was 10 years old at the time, and I was in the middle of an ice hockey game in Springfield, Massachusetts. And one of my teammates took what seemed to be a minor hit to his body. He got checked into the boards, and apparently he considered himself quite injured from this particular impact. And as the teammate approached the bench in apparent suffering, I could see that his legs were weak and he was tending to have his legs give way on him. And in fact, as he approached the door to the player's bench, his legs indeed gave out on him and he collapsed on the ice before successfully exiting the ice. So the referees blew the whistle, play stopped as we attended our injured teammate. Well, as it turned out, after we got him to his feet and asked him if he was okay and questioned him about his condition, it turned out that his condition involved a small cut on his upper lip. That was his injury. His injury involved a small cut on his upper lip. And here he was approaching the bench with his legs giving way in apparent weakness and give way of all strength of his body for nothing more than a small cut on his upper lip. And even though I was only 10 years old at the time, I thought about the inconsistency of this observation, and I wondered to myself, in my naivety at the time, how would his legs tend to give way on him when the injury involved a small cut to the upper lip? And this was an example of an emotional player who was displaying great pain, attempting to display great pain through his pain behavior, and yet the pain behavior was not consistent with the specific injury that he suffered. The specific injury that he suffered was a cut to the upper lip, which would seemingly be unrelated to the strength of the lower extremities. So key point is that those pain behaviors that tend to validate an individual's pain are generally very specific to that person's injury and very specific to that person's medical condition. And so as we go through the pain behaviors, we're going to take a look at each of the pain behaviors and we're going to ask ourselves, what type of specific injury is it, or what type of specific injury could it be that could cause this particular pain behavior? And we're going to see that, at least for the pain behaviors that are described in the AMA guides, the injury responsible for the noted pain behavior is a very specific injury. And so it becomes actually quite easy to make a decision as to whether or not the examinee is displaying consistent or inconsistent pain behaviors. Okay? So let's go over the list of pain behaviors described in the AMA guides. Okay, so here they are. These are the pain behaviors. These are described in Chapter 18 of the AMA guides, page 580, Table 18.5. Number 1, facial grimacing. Facial grimacing. Have you seen or have you observed your examinee to employ facial grimacing as a pain demonstration? Let me ask you, what types of conditions, what types of maneuvers, what types of manipulations of the examinee could result in facial grimacing? Well, that's open to discussion, but let me ask you, could an injury to the spine cause an examinee to employ facial grimacing if pain was sparked in that area of the spine wherein they suffered industrial injury? I think it could. What about the upper extremity? Could the examinee employ facial grimacing if pain was reproduced in an upper extremity injury? I think so. Probably lower extremity as well. Would you agree? So facial grimacing is sort of a general pain behavior that can be present in a wide variety of injuries and a wide variety of conditions. But the key point is that the facial grimacing should happen in conjunction and in unison with some type of a maneuver or manipulation that causes movement or reproduces the examinee's pain or stimulates the examinee's pain generator. So in the absence of any type of movement or restimulation of the examinee's pain generator, we would not expect to see facial grimacing. Okay? In other words, facial grimacing with the examinee at rest would seemingly be an inconsistent pain behavior. How about holding or supporting an affected body part or area? Have you ever had an examinee come to the physical examination holding and supporting their upper extremity in one hand? I have. I once had a female examinee with an upper extremity shoulder injury, and she presented and she sustained this posture throughout the entirety of the interview and the physical examination, holding and supporting her entire upper extremity with her other opposite upper extremity. How about limping or distorted gait? Limping or distorted gait. Let me ask you, what type of injury would you expect to see limping or distorted gait? Would you expect to find limping or distorted gait to be associated with an upper extremity injury? Probably not, correct? But it certainly could be associated with a spinal injury or a lower extremity injury. And when I think of limping or distorted gait, I'm reminded of tennis player Andy Murray, who I was watching just last night in a tennis match. And I don't know if you're a tennis fan, but tennis player Andy Murray recently underwent a surgical procedure of his right hip. And now as he's attempting to recover and rehabilitate from that injury, and he's re-entering the world of competitive tennis, I can see that he still has some positive objective pain behaviors associated with the injury and the surgical procedure to his right hip. Because even in the rested condition at the beginning of the match, he has a noticeable shortened stance phase and limitation to right hip extension of the right hip. He has a shortened stance phase on the right due to limited extension of the right hip. And as the match progresses and as the yards and miles accumulate, the running miles accumulate, the limp becomes more pronounced. So this is a positive objective observational pain behavior finding that supports his history, that's consistent with his history of injury to the hip, and it's consistent with his history of surgery, recent surgery to the right hip. So limping or distorted gait is something that we would expect to see in cases of bona fide spinal pain or bona fide lower extremity pain. as the examinee employs some evasive action to get away from the pain. It's interesting, a limp, an antalgic limp, is nothing more than an evasive action away from the pain. So I can tell where Andy Murray's pain is. His pain is to be found in hip extension. He limps to avoid and evade hip extension. So limping and distorted gait should be consistent with the examinee's spinal or lower extremity injury. How about frequent shifting of posture or position? This is a type of pain behavior that can be seen in a variety of conditions, both in the upper extremity, both in the spine, and also in the lower extremity. And it's important to note what posture or what position is the examinee shifting away from. So with an upper extremity injury, we would expect to see the examinee frequently shifting the posture or position of their upper extremity. With a spinal injury, we would expect to see frequent shifting of posture or position of the spine in the case of a spine injury. With a lower extremity injury, we would expect to see examinee frequently shifting the posture or position of their ankle, of their knee, of their hip, of the lower extremity. So the frequent shifting of posture or position should be consistent with the known industrial injury. How about extremely slow movements? Have you had examinees go through spinal ranges of motion and proceed through those ranges of motion very cautiously, very slowly? This is a positive physical examination finding. This is a positive pain behavior that should be consistent with the examinee's known condition. Now, in an examinee with a known injury to the spine, we would not expect to see them employ extremely slow movements of the upper or lower extremities in physical examination. The extremely slow movements should be, of course, associated with the spine. How about sitting with a rigid posture? What type of an injury would most likely cause an examinee to sit with a rigid posture? Well, this would most commonly be associated with a spinal injury, either an injury to the cervical spine or possibly even an injury to the lumbar spine, but it could also be associated with an injury to the upper extremity as the examinee sits rigid in a manner to avoid moving a painful upper extremity body part, like for example a post-surgical shoulder, just as an example. How about moving in a guarded or protective fashion? Again, that's a lot like extremely slow movements, and it's important that the guarded and protective movements be consistent with the examinee's known injury and consistent with their known condition. How about moaning? How about moaning? Now, moaning is a verbal communication, a verbal pain behavior. And I know you've had examinees who have employed moaning in the physical examination to indicate to you that they're indeed experiencing pain with your physical examination maneuvers. The question becomes, and as we go back to our twofold tasks as the examiner, we need to ask ourselves, is the moaning consistent and proportional to the examinee's known condition? Some examinees are excessive and enthusiastic moaners, and they moan to such an extent to be out of proportion to the physical examination maneuver purported to cause them pain. So we need to always be making an assessment as to whether or not the moaning is in proportion to the physical examination maneuver purported to be the cause of their pain. And some examinees will moan non-specifically. They will moan to manipulation of all body parts rather than to the specific body part involved with the industrial injury. So it's important to make this observation as to where in the physical examination the moaning occurs, and is the moaning in proportion, is it proportionate to the physical examination maneuver purported to be the cause of their pain. How about using an assistive device such as a cane, a cervical collar, a knee brace, a carpal tunnel splint? When you observe examinees presenting to the face-to-face evaluation with these assistive devices, the first question that you want to ask yourself is this a medically necessary assistive device? In other words, is this an assistive device that was prescribed by the primary treating physician to cure and relieve the effects of the industrial injury, or is this simply an assistive device that the examinee is employing to impress the examiner as to the great extent of their suffering and the great extent of their pain? I once had an examinee present to the face-to-face evaluation with a cane, and I asked him if the cane was prescribed to him by the primary treating physician, and he informed me that no, it was not prescribed by the primary treating physician, but rather he picked it up at a flea market for $1.50, and he self-prescribed it to himself. And there was no indication in any of the medical records that I reviewed that any doctor had recommended or prescribed an assistive device for his condition. So when we observe examinees presenting to the evaluation with assistive devices, it's important to determine whether or not the assistive device is a medically necessary device and whether or not the assistive device is consistent with the known industrial injury. In other words, we wouldn't expect to see an examinee with a knee brace for an upper extremity injury. Okay? Finally, what about the pain behavior of stooping while walking? What type of an injury do you think could cause stooping while walking? Well, I don't know about you, but the first thing that comes to my mind would be a lumbar spine injury that causes a flexion antalgia and prevents the examinee from standing straight up into full lumbar spine erect posture. And so typically we would associate stooping with walking with a lumbar spine injury. In other words, we would not expect to see stooping while walking with an upper extremity injury. So if you notice this, this list of pain behaviors described in Table 18.5, most of these pain behaviors are associated with very specific injuries. Some of these pain behaviors we would expect to see only with certain specific injuries, and we would not expect to see them with anything but that specific injury. Other pain behaviors are more generalized. Pain behaviors can be seen across a wide variety of conditions. In those cases, the generalized pain behaviors should also be accompanied by some of the more specific pain behaviors as well, which would assist in corroborating the examinee's sincerity and the examinee's true painful condition. What about some other pain behaviors? Well, here's some pain behaviors not described in the AMA guides, but are illustrative for our purposes in the face-to-face evaluation. So, for example, guarding is described as abnormally stiff or interrupted or rigid movement while moving the joint or body from one position to another. And this can be associated with movements of the upper extremity, of the spine, and also of the lower extremity. Bracing is a stationary position in which a fully extended limb supports and maintains an abnormal distribution of weight. It's commonly seen in the lower extremity, where the examinee places a greater proportion of their body weight on the healthy lower extremity in order to evade and avoid pain on the injured lower extremity. Again, these pain behaviors are nothing more than manifestations of evasive action as the examinee attempts to maneuver and manipulate themselves away from the point of pain. How about rubbing? Rubbing is any contact between the hand and the injured area, such as touching, rubbing, or holding the painful area. This is similar to what the AMA guides describe as holding or supporting the affected body part. And when I think of rubbing, I think of a workout partner that I have now guy I work out with in the mornings, and he's constantly holding and rubbing his forearm where the extensor tendons attach onto the lateral epicondyle of the humerus. He's forever pressing, rubbing, massaging that area, which indicates to me that he has pain in that area. And yet it seems that this pain, whatever pain he has in this area, qualifies only as minimal pain, because what can be stated for certain is that this particular workout partner of mine is able to go through each and every single exercise with many sets and many repetitions with great loads. And he's able to successfully complete all maneuvers. So whatever pain he does have does not significantly interfere with the performance of the activities that cause the pain. And so therefore the pain, whatever pain he's having, qualifies in my estimation only as minimal pain. So this is another example of the type of assessments that we need to make when we observe our examinees demonstrating these pain behaviors. And that is the pain behavior reflective of a sincere and bona fide pain? And then number two, how bad is that pain? Does the presence of pain indicate the presence also of an impairment? And we know that that's not necessarily true. So this is just another one of the assessments that we need to take into account when we observe examinees employing these various different pain behaviors. We talked about grimacing, which is an obvious facial expression of pain. May include a furrowed brow, narrowed eyes, tightened lips with the corners of the mouth pulled back, and also even clenched teeth. And sometimes you'll see your examinees grimace in various ways. Finally, sighing. Sighing is considered to be a non-physiologic pain behavior because it usually involves an obvious exaggerated exhalation of air, usually accompanied by the shoulders first rising and then falling, and patients may first expand their cheeks prior to a long, prolonged, and dramatic exhalation of air. So these are some of the observations that you can make in the first 10 to 15 seconds in the face-to-face evaluation with your examinee, and you're going to continue to be acutely attuned to pain behaviors throughout the duration of the interview and the physical examination, always asking yourself whether or not the pain behaviors are concordant with the known injury and concordant with the examinee's known physical condition. Okay? So these are typically described as pain behaviors. What are some other positive objective findings that we can observe in our examinee without even touching the examinee or without even going through physical examination maneuvers? Let's touch upon some of those now. So some of the things that you want to observe your examinee for, and this is not a complete list, but these are some easy observations that can be made casually in the waiting room or in the interview with the examinee. Has to do with normal body alignment. For example, if you draw a plumb line down the front of the examinee, or if you draw a plumb line on the lateral aspect of the examinee, of course, the shoulders, of course, should be level, the hips should be level. There should be no obvious deviation from a central plumb line, either from the front or from the side. From the side, the external auditory meatus should line up over the acromioclavicular joint, which should line up over the lateral malleolus of the fibula bone. And any deviations from this normal body alignment could constitute a true positive objective physical examination finding. For example, from the lateral aspect, if you were to see an anterior flexion antalgia of the lumbar spine, this may give you an indication of the examinee's condition of the lumbar spine. As we know, flexion antalgia of the lumbar spine is a positive physical examination observational finding for lumbar spinal stenosis. Similarly, cervical spinal stenosis causes a forward flexion antalgia of the cervical spine. So these are just some examples of some deviations from normal body alignment that could serve as true positive objective physical examination findings to support the examinee's condition. Okay? What about any obvious deformity? These are some obvious deformities, are things that are readily detectable. If the examinee has, for example, flexion contracture of some various fingers, or the examinee has a scoliosis deformity, or a thoracic kyphosis deformity, or genu varum or genu valgum. These are some things that you can easily spot simply by observing the examinee. These findings could support the examinee's injury condition and could support the examinee's subjective findings if they are consistently related. Bony and soft tissue contours. You want to make an assessment of the bony and soft tissue contours and determine if those contours are normal or are abnormal. For example, is there any evidence of muscle wasting? Muscle wasting or atrophy is a true positive objective finding following an injury. And we know that muscles can undergo wasting through a variety of physiologic processes, including denervation, including reflex inhibition. So this would be an example of a soft tissue contour that could serve as a true positive objective observational finding. Are the limb positions equal and symmetric? You want to compare limb positions for size, for shape, for muscle tone, for texture, and even for temperature. And they should be symmetric. They should be equal and symmetric bilaterally. In the absence of bilateral symmetry, that finding could be a true positive objective physical exam finding. What about the examinee's gait? This is one of the most easily observed observational physical exam findings that we have at our disposal, because the examinee has to walk to the examination room from the waiting room, and it serves as a perfect opportunity to get a look at the function of the examinee. So some obvious gait disturbances that are described in the AMA guides include an antalgic gait, include a Trendelenburg gait, include a drop foot gait. And if you're familiar with gait observations, these are some readily detectable observations of gait or gait disturbances that even a novice can ascertain. Now, I was fascinated, as I mentioned earlier in an earlier slide. I was watching Andy Murray, the tennis player, play tennis last night, and it was interesting because the commentator was describing Andy Murray's condition by referencing pain and limping on the left lower extremity, when in actuality Andy Murray's injury was to the right lower extremity. It was an injury to the right hip. So even though the sports commentator was not a medical expert and could not accurately localize wherein the limp was generating from, even as a lay person, he was able to detect a limp. So some of the gait disturbances, even though you may not be able to accurately or immediately characterize the disturbance of gait, these gait disturbances stick out like a sore thumb when you're paying attention for them. Okay? And finally, some additional observational findings that can give us great information about our examinee have to do with the color and texture of the skin. Is the color and texture of the skin normal or abnormal? Talking about the color and texture of the skin over the area of the industrial injury. So we know that various injury conditions can affect the color and texture of the skin. And for example, we know that causalgia or reflex sympathetic dystrophy, or what the AMA guys refer to as chronic regional pain syndrome, can induce trophic changes to the skin and cause thickening of the skin, loss of hair follicles of the skin, loss of sweat gland function of the skin. So this is something that you want to pay particular attention for, which serves as a true positive objective finding in support of an active symptomatic condition. Are there any scars associated with the area of the injury? Is there any crepitus, snapping, or abnormal sound of the joints? Many of these sounds can be heard simply as the examinee moves around the examination room or moves from the waiting room to the examination room. Are there any signs of inflammation, such as redness, such as heat, such as swelling, such as tightness? These are all indications of persisting chronic inflammation that serves as a true positive objective physical examination finding. These cardinal signs of inflammation are common in the lower extremities, particularly around the ankles and around the knees, and when present, indicate to us that there is active symptomatic inflammation in this area, and this serves as a true positive objective finding. What is the patient's attitude? We know that acute pain can cause patients to be anxious, whereas chronic pain can cause patients to become depressed. So it's important that we pay attention to the examinee's energy level and the examinee's attitude as they go through the physical examination, because this gives us an indication as to the true nature of their condition. What is the examinee's facial expression? And finally, is the examinee willing to move? Are they willing to move the body part, or are they moving in a guarded and protected fashion, holding and supporting and moving with extremely slow movements? In the presence of some of these other more positive indications of an active process, such as cardinal signs of inflammation, this could give us further support to corroborate the examinee's description of their injury and their painful condition. So in concluding today's video, it's important that we pay close attention to our examinee and the way they communicate to us both verbally and non-verbally. And many of the pain behaviors and the observational findings that we're going to be able to ascertain are given to us by the examinee through non-verbal means of communication. So the examiner needs to keep one eye open to what it is that the examinee is telling us non-verbally. And many of these observational findings can serve as true objective physical examination findings when they are consistent with the known injury and when they are consistent with the known condition of the examinee. Okay? Now, in our next video, we're going to go into true positive objective physical examination findings associated with the neurologic examination. And I want to focus on the neurologic examination because it seems that many doctors have misconceptions about the neurologic examination of the spine compared to the neurologic examination of the upper extremities, compared to the neurologic examination of the lower extremities. And even though the neurologic examination of these various neural structures have several features in common, they have many anatomic features that are different, that are unique to the structures being evaluated. And I want to go over the specific anatomy, the specific injuries, and the specific examination procedures unique to the spine, to the upper extremity, and to the lower extremity. So for today, this is Dr. Perry Carpenter. I want to thank you for taking the time to join me on today's video. Look forward to being with you on our very next video as we continue our ongoing series entitled Orthopedic Essentials for the Qualified Medical Evaluator. For now, I'm wishing you best of success in your career as a qualified medical evaluator.